Welcome to this brief recap presentation from ADPD on the use of the Cogstate Brief Battery in ADNI3. My name is Chris Edgar and I'm the Chief Science Officer with Cogstate. The Cogstate Brief Battery, or CBB, has been designed as a 15-minute digital computerized cognitive test battery. The CBB has a game-like interface which uses playing card stimuli and requires participants to provide yes or no responses. The battery consists of 4 tests: detection, identification, one-card learning, and one back. Each of these tests poses a simple question to the participant, with each probing a different primary cognitive domain. For each of these tests, the software records speed, reaction time, and accuracy of performance. The CBB has been evaluated in several studies exploring cognitive impairment and cognitive decline associated with Alzheimer's disease. A composite accuracy outcome from the one-card learning and one-back tests, termed learning and working memory, has consistently shown sensitivity to both cognitive impairment as well as pathological changes associated with Alzheimer's disease. The data in figures A and B show that the presence of abnormally high amyloid is associated with a substantial decline in performance on the learning and working memory composite in both cognitively normal adults and in older adults who meet clinical criteria for mild cognitive impairment. The CBB has also been modified for unsupervised and bring your own device assessment. For the unsupervised version of the CBB, the tests remain the same, but the design and implementation of the instructions has been modified using a shaping approach to ensure individuals understand the context for decisions and response requirements prior to beginning a test. This is achieved by ensuring response requirements are trained without the need for written instructions. Following this, a simple test rule is introduced, and then test rules can increase in difficulty over the 4 tests. The use of BYOD assessment is further supported by completion via a web browser, with participants required to complete their cognitive testing on a desktop or laptop. Tests are downloaded for completion locally on the device, and completion data uploaded to minimize any impact of internet connectivity. Using this web-based unsupervised BYOD approach, data have been collected as part of the Healthy Brains project. Perrin et al. Have reported on the acceptability, usability and validity of this web-based unsupervised approach to assessment with the Cogstate Brief Battery. In this study, data were available for a total of 1,594 participants who were community-dwelling adults between 40 and 65 years of age and with a self-reported family history of dementia. These individuals completed the CBB on a single occasion as part of their enrolment into the project. These data have shown the validity of the tests appear to be maintained, with expected effects of age on speed of performance, i.e. longer reaction times in older age groups. Additionally, the effective test environment was explored within a subset of participants, 62% of those completing a survey of their usual testing environment. Most participants completed cognitive tests at home or at work and reported either being alone or with others but in a quiet environment, and no clear effective environment was identified in these analyses. Perrin et al. Also applied a human-computer interaction framework to evaluate the CBB tests for their acceptability and usability. Here, acceptability was defined by missing data, and more specifically the failure to complete a test once it had been started. Overall, missing data occurred for 30 instances of the detection test, around 2%, and 10 instances of the identification test, less than 1%, but not for the subsequent tests. Importantly too, these are the first tests in the battery, indicating a small proportion of participants may quit early on, but the vast majority complete all of the tests once started. In the table presented here, we see the data for one-card learning, which is the 3rd test in the battery, and for which there was no missing data. Usability was defined in 2 ways. First, a performance metric, and for one-card learning this was defined as performance less than chance, which would indicate the requirements of the test were not understood. And in this case we can see that 86 participants, or around 5%, had issues with this usability criterion. Second was time spent on reading the instructions, compared to prior data in the supervised assessment context, which was used to identify participants who were more than 2 standard deviations away from the normal supervised completion time. For one-card learning, this identified 11 participants, less than 1%, who had issues with this usability criteria. And we will return to these same criteria when we look at the ADNI3 data. ADNI then was launched in 2003 as a public-private partnership, with the latest iteration of the study being ADNI3. In ADNI2, a pilot evaluation of the CBB was conducted in a subset of 189 cognitively normal and mildly cognitively impaired participants at selected sites, and who were offered the opportunity to complete the CBB both in clinic and at home. Of these people, 55%, 104, consented to undertake the CBB assessments. These data supported the feasibility of the CBB, and the assessment was then formally included in ADNI3. In ADNI3 then, participants first complete the CBB at an in-clinic supervised assessment, and then subsequently at home unsupervised 1 month later, and at up to quarterly intervals in between in-clinic visits, which are yearly for mild cognitively impaired participants and every other year for cognitively normal participants. Acceptability and usability were evaluated for ADNI3 using the same criteria previously described, with acceptability evaluated as missingness following test initiation. These data showed high levels of usability and acceptability, greater than 98% in all cases. Of note, acceptability and usability are further supported in ADNI3 by prompting repeated assessment. If a test returns incomplete or errorful data, the participant is prompted to give the assessment another try, up to a maximum of 3 times. Only a small proportion, less than 10% of participants, required a second attempt, and less than 3% a third attempt for any test. Known group's validity was also well supported, with statistically significant and small to medium effect size differences evident between the cognitively normal and MCI groups of the first in-clinic assessment. These differences all reflecting poorer performance in the MCI group, and with the largest difference, a Cohen's d of 0.7, being for the accuracy outcome from the one-card learning test. In contrast to the known group's validity, differences between the first in-clinic assessment and the first at-home assessment showed only small or trivial effect size differences, and this is consistent with some prior data that have shown no effective setting in the context of concussion assessment with the CBB. There is now a large sample of ADNI3 participants for the first in-clinic supervised CBB assessment, with 629 participants in total. This number dropped substantially for the first at-home assessment, with only 58% of the participants completing this. Of note, the instruction per protocol is that assessment may be up to quarterly. Additionally, different degrees of support and reminders have been given at the site level, with both in-clinic, annual or biannual, and potentially quarterly telephone reminders, but without explicit or standardised procedures. In conclusion, these data support the acceptability and usability of the CBB in ADNI3, as well as providing support for their sensitivity to cognitive impairment in the MCI population. Whilst the data also suggest equivalence between the first in-clinic supervised and first at-home unsupervised assessments, there is work to do to separate out potential effects of repeated assessment, supervision, and setting. Prior publications have conflicting findings in this respect, and dedicated studies may be required. It is clear that adherence to longitudinal assessment with remote and unsupervised approaches presents a substantial challenge both for ADNI and the field in general. We know that adherence in clinical trials more broadly is not solely related to invasiveness, burden, or, contrastingly, entertainment, ease, or value, though these may be important. We also know that adherence to remote and unsupervised assessment may be low in some participants, that we may also be able to support adherence in multiple ways. We should then think carefully about how we engage with and communicate with participants to foster a shared sense of value around all of the data that we collect, as well as addressing any barriers such as accessing the assessments, the time commitment, and issues around scheduling and remembering to complete assessments. Greater support can certainly be offered for remote assessment in ADNI and other remote assessment studies, and we continue to explore alerts and reminders, device compatibility, including smartphones, and other means of support. Thank you for listening. I hope this talk and the full session are informative and look forward to feedback and questions.